Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled, How Did State Governor Directives Change Healthcare Workforce Flexibility in Response to COVID-19? And it was presented on November 17th, 2021 by Margaret Ziemann and Julia Strasser. My name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today's webinar is entitled, How Did State Governor Directives Change Healthcare Workforce Flexibility in Response to COVID-19? With that said, before we get started, I have an announcement. On December 16th, Cleese Erickson and Candace Chin will be presenting COVID-19's effect on access to care for underserved populations, an examination of telehealth and provider attrition. Now, with that said, let me go ahead and introduce you to today's speakers. Today we have Margaret Ziemann and Julia Strasser, both from the Milken Institute School of Public Health at the George Washington University. Welcome.
Thanks, David. And I'm going to share our slides here in just a minute. Let's see. So my name is Julia Strasser. I'm a senior research scientist in the Fitzhugh-Mullen Institute for Health Workforce Equity at the George Washington University. And along with my colleague, Margaret Ziemann, I'll be presenting today on state executive actions that changed healthcare workforce flexibility in response to COVID-19. So first, Meg and I just want to acknowledge the contributions of our research team, which is listed here, as well as the generous funding support from HRSA. So by way of background about this study, as you all likely remember, the onset of the COVID-19 crisis resulted in immediate shortages of staff, supplies, and space in the healthcare setting. There was an immediate need for increased workforce and for increased workforce flexibility, especially in March and in April of 2020. However, there was minimal coordination between federal and state policy, as well as a lack of a coordinated national response to COVID-19. And so the onus was left on states, and specifically on governors, to navigate and respond quickly to the crisis. So when we think about workforce flexibility, state policy is especially important. So at the state level, scope of practice or SOP policies can limit advanced practice registered nurses, also called APRNs, and physician assistants or PAs from practicing at the top of their education and license. Pharmacists also have the ability to provide some medical services and are also constrained by some scope of practice policies. In addition to scope of practice, licensing policies can regulate education, training, and the exams required for a clinician to be able to practice in a particular state. Because scope of practice and licensing policies are determined at the state level, they differ significantly across the country, even amongst neighboring states. When we think about state policy during an emergency, we want to think particularly about governor-issued executive orders. So governors have the ability to issue executive orders for expedient policy directives, and that's especially important in times of emergency because the legislative process can often be slow and is not usually suited for urgent matters. In all states, when an emergency declaration is passed, that it triggers emergency powers that the governor can use, and that includes executive orders. So the purpose of our study was to examine governor-issued executive orders that contain explicit directives that either expanded scope of practice for APRNs, PAs, or pharmacists, or permitted healthcare providers with out-of-state licenses to provide care during COVID-19. So for the methodology for this study was an in-depth document review of all state governors' executive orders related to scope of practice and licensing that were introduced in 2020. We reviewed both primary sources, so specifically executive orders pulled from state websites, as well as secondary sources, National Governors Association, National Council of State Legislatures, Council of State Governments, and others that reference primary source material. For our inclusion criteria, we set governor-issued directives that explicitly address scope of practice for APRNs, PAs, or pharmacists, or cross-state licensing. We excluded policies that were related to surging the healthcare workforce, such as re-entry of retired professionals or early entry of students into the healthcare workforce. And we also excluded policies that were not directly issued by the governor. And that includes policies that were issued by state agencies. And sometimes when we've presented this research before, we've gotten questions about that. And so we just want to be explicit about what we have included and excluded here, and that is governor issued directives. So with our policy language, we conducted a thematic content analysis using an inductive process. We did not identify themes a priori to allow for flexibility in our coding. We categorized our policies for all states plus DC under 4 types of policies. So scope of practice for APRNs, scope of practice for PAs, scope of practice for pharmacists, and licensing for all professions. And then you'll see sort of asterisks there, APRNs and pharmacists, because for those categories, we reviewed our categorization strategy with relevant professional societies to get expert input. And then for the 3 scope of practice types, we created a ranked category for each of the professions, where the first category maximized flexibility. So usually waiving collaborative practice agreements or supervision requirements. And then category 2 provided some amount of increased flexibility, but anything less than the maximum. And we'll get into that with the results. So based on the categories that we determined in the previous step, we also indicated the change from pre-COVID policy, and determined the pre-COVID policy. We relied on existing analyses by expert groups within the relevant profession or the policy type. So the map that you see here, for example, is from AANP, and that describes whether states are full scope of practice, reduced scope of practice, or restricted scope of practice states. And for APRNs, full scope of practice states do not require a collaborative practice agreement. And so we found that pre-COVID, there were 23 states that were full scope of practice states for APRNs. For PAs, states are considered full scope of practice if they have 5 or 6 elements out of a total 6 of a modern PA Practice Act. And there were 24 states that met that requirement. For pharmacists, we use the indication of whether the state allows prescription adaptation, and there were only 3 states that met that requirement pre-COVID. And then lastly, for licensing, we indicated whether a state was party to a nurse licensure compact as of the beginning of the pandemic, and there were 21 states that fell into that category. So moving on to our results. So this is kind of an overview of the national landscape where we identified executive orders. So we found executive orders in 36 states that had explicit directives issued by the governor that addressed either scope of practice or out-of-state licensing or both. Of those 36, there were 20 states that issued executive orders related to both scope of practice and licensing. And you can see that here in the middle of this Venn diagram, what the states were. We found 12 states that issued executive orders related to licensing, which you can see here in this kind of purple section, but not on scope of practice. And then lastly, there were 4 states that issued executive orders on scope of practice, but not on licensing. So thinking about sort of the details of the way that we categorize these executive orders. So for APRNs, there were 17 states that reduced regulatory barriers related to scope of practice. For category 1, as I mentioned in the results, we identified states that maximize flexibility for APRNs, and there were 11 states that fell into this category. And specifically what we mean is states that completely waived the requirement for a collaborative practice agreement or CPA between APRNs and a supervising physician, or else broadly removed limits on the services that could be provided under an APRN's scope of practice. And then category 2, which had 6 states, included policies that eased some type of supervisory restrictions or administrative burdens, but stopped short of completely waiving the collaborative practice agreement requirement. So here you can see the results table for APRN scope of practice, and we have the state listed here, and then what the state environment was before COVID. And then we've got indicated whether the state was a category 1 or a category 2 state. And then the final column on the right shows details and additional notes of the policy. And this is the content that we used to categorize the way that states addressed flexibility of their workforce. I'm not going to go through every single state, but I'm going to pull out a couple of examples so that you can have a sense of kind of the way that we categorize these. So for example, in Kansas, which we categorized as a level 1 state, they completely waived the collaborative practice agreement requirement for APRNs. I wanted to also highlight Maryland and Nevada, which were both category 1 states. They used sort of this broad language that allowed all medical practitioners to practice outside of the scope of their specialization or outside of their scope of their license, which was a little bit unusual, but we wanted to categorize them as maximizing flexibility. And then also just to give an example of a category 2 state, so you can see here in Connecticut, they suspended the requirement for a physician to be physically present for CRNAs during surgery. So that provides some expanded flexibility, but again, falls short of waiving the collaborative practice agreement requirement. So then similarly for PAs, we identified executive orders in 17 states that included explicit directives from the governor. There were 12 states in category 1 that maximize flexibility. So they either completely waive supervision or delegation agreement requirements or broadly remove limits on services that PAs could provide. And then category 2, which we forgot to indicate here the number, but I'll get into it on the table, that expanded practice flexibilities here. So where they relieved administrative burdens or eased supervisory restrictions, but again, fell short of waiving supervision or delegation agreements completely. And so similarly, as with the APRN table, you can see here the state, the number of elements of a modern PA Practice Act as of February 2020. So that was the state's pre-COVID policy, and then whether the state was a category 1 or a category 2. And just again, to highlight a few examples of the way that we categorize the language here. So in Louisiana, they waived the supervision requirement. And then you'll see it's the same language here for Maryland and Nevada as we use for APRNs, because it includes, in Maryland, it says all healthcare practitioners, and in Nevada, it says all providers of medical services. So again, allowing PAs to practice outside of their license or outside of their scope. And then for category 2 state, for example, in Alabama, they made supervisory ratios unlimited, but again, did not waive the supervision or delegation agreement entirely. And then lastly, for pharmacists, we identified executive orders in 9 states that included explicit directives from the governor. Category 1, it indicated whether they expanded practice authority, so allowing a broader scope of services that pharmacists can provide. And category 2 indicated whether they could provide extended prescriptive authority, so emergency refills or therapeutic substitution. And in the next slide, I will focus on category 1. So here you see the state, what the state law was related to prescription adaptation before COVID, and then whether they were a category 1 or a category 2 state. And I will draw your attention here to Kansas and Michigan, where executive orders allowed pharmacists to provide care for routine health maintenance condition, chronic disease states, et cetera, without physician supervision. And so allowing a lot of flexibility there for pharmacists. And so now I'm going to hand it over to my colleague, Meg, to talk about licensing.
Thank you, Julia. So we also identified executive orders in 31 states and DC that included explicit directives from the governor that eased or waived licensing regulatory barriers to allow out-of-state healthcare practitioners to practice in state during the declared state of emergency. And I should mention that for this assessment, we focused only on executive orders that would have allowed physical practice, in-person practice. This is not looking at telehealth across state lines. So among these 31 states and DC, 21 of the states were already party to the nurse licensure compact at the beginning of the pandemic. And that's denoted in bold on these slides. And we point that out because we use NLC participation as an indicator of states' pre-COVID openness to licensure flexibility across health professions. As you can see in this table, in 18 states and in DC, these executive orders referred to healthcare providers collectively when granting out-of-state licensing flexibility. But when policies granted this flexibility to only certain professions, they were most frequently directed to medicine and nursing. Next slide, please. So I want to return to take a closer look at what was happening in a few states to provide some potential explanatory context or shed lights on the implications of some of these executive orders. So first, in Michigan, Tennessee, and Virginia, these were 3 of the most restrictive practice states for nurse practitioners prior to the pandemic, as determined by the classification from AANP that we showed at the the beginning of this presentation. However, in all 3 of these states, the governor issued executive orders that completely waived collaborative practice agreements. So for advanced practice nurses in these states, these executive orders may have represented temporary transformative changes to the practice environment. That said, these orders expire along with the emergency declarations, and we know that those emergency declarations have already expired in many states. Next slide, please. In Maine, the governor issued executive orders that waived collaborative practice agreements for nurse practitioners, supervision requirements for PAs, and permitted out-of-state license holders to practice in the state of Maine. Yet it was already a practice-friendly state in that it was a full practice state for nurse practitioners. It was permissive for PAs based on the 6 elements of key practice for PA Act. I'm sorry, I got that wrong. And it was also already party to the nurse licensure compact. So this begs the question, why would a governor have issued these explicit policy provisions? And there are likely many reasons, and additional qualitative work is certainly needed to understand these actions. But one reason may be to address prior policy gaps. So in the case of Maine, physician supervision was still required of advanced practice registered nurses and PAs during their first 2 years of practice prior to COVID. The language in the executive order would have permitted these clinicians in the first 2 years of practice to practice without supervision during the emergency, expanding workforce capacity. Next slide. My colleague has already pointed out the states of Nevada and Maryland. They're highlighted here just to say that they were unique and that their EOs explicitly permitted healthcare practitioners to practice outside of the scope of their specialization, and in the case of Maryland, even outside the scope of their license. Next slide, please. We highlight Michigan because it was the sole state that we identified in which governor issued executive orders explicitly waived supervision requirements for all advanced practice clinicians, expanded the practice and prescriptive authority of pharmacists, and permitted out-of-state licensed healthcare practitioners to practice in the state. This represents an aggressive executive response to expand health workforce flexibility, as well as a departure from the state's non-emergency policies, which were restrictive for advanced practice nurses. However, as with many other states, the state's emergency declaration has ended, and along with it, these emergency workforce policies. Next slide. And the last state snapshot that I want to share is for 8 states. We highlight these 8 states where a governor issued executive order explicitly authorized nurses holding out-of-state licenses to practice, despite the fact that these were states that were already party to the nurse licensure compact prior to COVID. The EOs in these states, the executive orders, may therefore seem unnecessary at face value. However, it's important to remember a couple of things. Number one, 13 states still do not belong to the nurse licensure compact. So these policies, emergency policies, would have allowed nurses from those states to practice across state lines. And second, even within nurse licensure compact party states, not all nurses belong to the compact. There's an application process involved. So again, these executive orders issued by governors would have applied to those nurses as well. Let's see, next slide, please. So to wrap things up in the discussion, governor's authority to respond to this public health emergency through their executive actions introduced an opportunity to expand health workforce practice flexibilities. In some states, as were just noted in the state snapshot slide, such as Michigan, Virginia, Tennessee, states with the most restrictive practice environment prior to COVID, the executive orders that were issued represented transformative policy changes and a potential inflection point in workforce policy for these states, albeit temporary. With regard to pharmacists, throughout the pandemic, pharmacists have played a key role in testing and community-based provision of vaccines. However, our research suggests that states did not fully leverage pharmacists' competencies to respond more broadly to population health needs during the early months of the pandemic. Only 2 states, as Julia pointed out, Kansas and Michigan, authorized pharmacists to provide care for routine health maintenance, chronic disease, and similar conditions. We also note that more states issued executive orders that explicitly granted out-of-state licensing flexibility than for those that expanded scope of practice, begging the question as to whether the issue of out-of-state licensing is not as politically fraught. There are a couple of potential factors related to this finding. One of them is federal support for interstate practice, and that at the beginning of the pandemic, Centers for Medicare and Medicaid Services 1135 blanket waiver allowed out-of-state practitioners to be eligible for Medicare and Medicaid reimbursement in states outside of that in which they were licensed. However, this federal action did not waive state laws or supersede them, necessitating that states also needed to waive their out-of-state licensing requirements for that waiver to apply in practice. Our findings therefore suggest that federal policies may be a driving factor in shaping state executive policy responses in times of emergency. Further, we note that the growing number of states party to the Nurse Licensure Compact and other occupational licensure compacts may represent growing political acceptance of the need for interstate collaboration to mitigate the challenges presented by a patchwork of state licensing policies in a nation of increasingly mobile workers. Next slide, please. So we note that the executive orders that we assessed were those that contained explicit governor directives related to scope of practice and out-of-state licensing. When an emergency declaration is issued, oftentimes workforce matters can be delegated automatically to state agencies without the governor needing to issue explicit directives, allowing governors to sidestep potentially contentious policy, workforce policy issues in the state. We, however, contend that governor issued directives lend visibility, intentionality, and public support to these issues. In future emergencies, especially natural disasters, we're going to require a robust workforce, and restrictive practice environments may make some of the most vulnerable states less appealing for advanced practice clinicians in particular. Next slide. We do want to acknowledge the limitations of our research. We recognize that executive orders alone don't necessarily reflect what is happening on the ground. We also acknowledge that other policies do shape the practice environment. This would include legislation or, as Julia mentioned, regulations put forth by state agencies, and that we excluded these executive orders. As with in any qualitative research, of course, there is also an extent of subjectivity to our classification of these policy categories. Next slide. We think there are opportunities for future research in this area. We think it's going to be important to continue to monitor states' practice environments beyond the emergency period, and to assess whether temporary practice environment changes have had an impact on broader efforts to relax policies, as well as to track workforce and patient outcomes associated with these emergency workforce policies. We also think it would be really interesting to perform additional qualitative research that would provide context for executive actions and explore on the ground impact, especially in those states for which the emergency orders really did represent pretty transformative practice environment changes. Next slide, please. In conclusion, governor issued executive orders are a very important policy mechanism for addressing health workforce needs in times of emergency. They can reinforce, augment, or replace existing health workforce policies. And in some cases, this can result in significant changes to states' practice environments, albeit temporary. COVID has the potential to be an inflection point in health workforce policy, especially as it pertains to advanced practice clinicians. But we need more research to determine what, if any, lasting impact these emergency policies will have on the longer term practice and policy environment. Next slide, please. I leave you with this slide that contains a quote from our Institute's founder, Fitzhugh Mullen, as well as some of our contact information and social media information. Please do feel free to email myself or Julia following this presentation with additional questions. But for now, we look forward to taking your questions during the Q&A portion. Thank you so much.
All right, thanks, Meg, and thanks, Julia. That's a wonderful presentation. And just a reminder to you in the audience, you may ask questions using the Q&A panel on your screen. Now, with that said, we do have a couple questions already in from the audience, but just kind of to begin, like a point of clarification, you've already touched on it a little bit, but just to be clear, you're only looking at governor's executive orders here. Are executive orders issued by state agencies like the health department included here? And if they aren't, and if they are, can you discuss a little bit more of your rationale behind your decisions?
I'm happy to start off, and Julia can chime in. No, we did not. We intentionally did not include policies issued by state agencies and other departments, and we recognize that those are important policy mechanisms for shaping the practice environment in states. We didn't do that for a couple of different reasons. Number one being that there is wide variation in how states respond to emergency declarations, and that in some states, agencies do get involved and the emergency declaration automatically triggers a response by them. In other states, that really doesn't happen. We wanted to make an apples to apples comparison by just looking at executive orders. I think I was going to make a second point that I'm blanking on now. Julia, do you have anything to chime in?
I think, I don't know if this is what you were going to say, but I think sort of as you alluded to on one of the discussion slides, I think we also felt like it was particularly important to focus on governor issued executive orders because of this issue of sort of visibility and lending public support for it. Like they have to sign it and it's got the seal of the state and in a way that's more, sort of visible than some of these state agency regs, which often maybe like a regulation related to a piece of legislation that was passed earlier. And so that was another reason we wanted to focus on it. And I think the other thing is, now it feels probably like to all of us that COVID has been going on for a very long time. But if you can put yourself back in the mindset of when we were back in March, April of 2020, I think there was a lot of focus on what governors were doing and how governors were responding. And so that was kind of another reason that we became interested in this.
Thank you. The intentionality point was the one I was going to make, so thank you.
Okay, thanks for the clarification. That helped out, I think. With that said, do you foresee any movement from states to make these temporary changes permanent, even after the public health emergency?
That's the big question. I'll again start off, and Julia, feel free to chime in. I think that there is hope on the part of some advocates and perhaps on the part of some professions that was going to be the case. I mentioned Michigan and how sort of aggressive they were in their response through executive orders to completely waive collaborative practice agreements and supervision requirements. And our understanding from the advocacy world is that there were some who had hoped that this would be the needed foot in the door to move the needle on lasting policy change. That as far as I know, that has not happened as of yet in the state of Michigan. And I do know that those policies have since been rescinded in the state of Michigan. We do note in a forthcoming manuscript based on this research that there is certainly some grassroots efforts on the part of nurses in particular. For example, in the state of Louisiana, Louisiana to use the response and the expanded workforce flexibilities and the success thereof during COVID as rationale to permanently expand workforce flexibility and expand scope of practice in that state. The state of Louisiana has gotten some media attention. I'm not sure where any legislation in reaction to that lies in that state. So yes, there is certainly hope that these would be sort of like the springboard for more lasting policy changes. That said, we are not tracking individual state legislation to see whether any of that has changed. And then if so, if it was a more direct response to these emergency orders or not.
Okay. Well, I guess we can move on to the next question. Thank you, Meg, for your answer. And just a comment from the audience, and I certainly agree with this one. It was an excellent presentation and very good presenter. So I will point that out to you, of course. Now, with that said, do you think there could be any significant differences in COVID-19 outcomes by changes in SOP flexibility? Is this a possibility?
So I'll start off with that one, and then Mike, feel free to hop in. So first, let me say I see that question was asked by Noah Westfall, who helped us a lot in the early stages of this research. So thank you, Noah, and thanks for the question. So
Noah.
Hi, Noah. So this is something we've talked about a lot. We don't have any specific plans to study outcomes in the sense of patient level outcomes like hospitalizations or mortality or even case positivity rates. I think that would be an interesting question for someone to look at as sort of a phase 2 of this. I think one of the things that we have talked about and be curious to see is whether it changes if you sort of broaden your definition of outcomes. So looking at sort of workforce specific outcomes, and so whether it had any kind of role in which practitioners were practicing in a given state. And I think other factors, like I know the Institute is involved right now, and maybe Meg can speak to this, in some work related to healthcare practitioner burnout. And so in states, where they were more restricted or had less flexibility, there may have been other sort of outcomes that also would be worth looking at in addition to these kind of like more sort of severe COVID specific outcomes. I'll see if Meg has anything to add.
No, I agree with everything that Julia said. I mean, when it comes to patient outcomes, what we do know is that there's a lot of good evidence demonstrating that when advanced practice registered nurses are allowed to practice to the top of their licensing and training, that their performance based on different quality indicators is the same as, it's certainly expanding scope of practice for advanced practice nurses does not harm patient outcomes. And in fact, there is some evidence showing that it can even improve patient outcomes when compared to the same outcomes for physicians. So we have that broader evidence base to go on. Now, we don't have any evidence, and it might be too soon to really critically assess the impact that any of these expanded scope of practice policies had on patient outcomes for COVID. I agree with Julia that there's definitely a need to do some additional outcomes-based research focused on workforce outcomes, capacity outcomes, burnout outcomes, and that's certainly a needed area of research moving forward, qualitative research as well.
Okay, thank you. A few questions here. What is the operational definition for prescription adaptation? Is this similar to prescriptive authority? And what was the main finding of this? Also curious, did you find the EOs sampled overall were more similar than not in scope and content? A few things there.
So I can start out maybe talking about pharmacists. I guess actually I'm going to answer your second question first, and then I'll do the other way. So I think there was some similar language across executive orders, but I think it's not like we found sort of a template where every state basically had the exact same language, and then they just either had that and we could kind of check the box. I think a lot of states had a lot of variation in the way that they described their policies. And we didn't specifically mention this in the slides, but one of the reasons that we wound up using, we included anything related to APRNs and not just specifically nurse practitioners, is that some states use language, some states said nurse practitioners, some states said advanced practice nurses, some states said APRNs. We also included certified nurse midwives. And so there was a certain amount of variation in the way that they talked about not only the policy language, but also sort of the category of professional that it applied to. Actually, I'm going to pause and see if Meg has anything else to say about that before we talk about pharmacists.
The one thing that I would add to that, I don't have numbers to share with you, but what we commonly saw was that in states where collaborative practice agreements were waived for APRNs, supervision or delegation agreements for physician assistants were also waived. So in many states, the policy as written applied to all advanced practice clinicians, APRNs, and PAs. There were the minority of states in which supervision requirements were waived for either of those two professions. In the minority of states we looked at, did that apply only to one profession? Usually it applied to both. So that would be the commonality that I most frequently observed.
And then I think about your questions on pharmacists. So prescription adaptation, I mean, as we understand it, and either, neither one of us is a pharmacist, so we'll be happy to have additional information from folks who are more knowledgeable about this sort of on the ground. But basically that it allows either dispensing of refills or therapeutic substitution. And that is distinct from prescriptive authority where, for example, in some states, pharmacists can prescribe contraception. And I think some others like related to smoking cessation as well. So it's a slightly different issue. And we wanted to indicate we wanted to use prescription adaptation because that was the most consistent pre-COVID policy that we could find that went across all 50 states plus DC. We also spoke with someone at the I can't remember, College of Clinical Pharmacy, ACCP. We spoke with a pharmacist in particular who's been tracking these issues. And one of the things that she suggested to us was that basically pharmacists are this sort of great untapped resource because they do have the ability and training to provide care for routine maintenance conditions and could have been an additional source of workforce flexibility, not just related to prescription adaptation or even prescriptive authority, but actually providing services. And so I think one of the sort of main finding is that was in all but 2 states. So that was kind of a missed opportunity not to tap into this resource to be able to expand their workforce flexibility by having pharmacists provide care for routine maintenance conditions.
Okay, thank you. And I have another question from another one of your colleagues. Did you notice wide variation in the clarity of the executive orders? When looking at audio-only telehealth policies during COVID-19, we found it could be quite challenging to determine the scope of the policy changes. If so, do you have any recommendations to future governors to make it easier to decipher?
Oh gosh, yeah, that's a great question. I'll start off there and just make a couple of different points. I don't know how clearly this is going to answer the question, but yes, we did notice that there was wide variation in clarity of language used in these executive orders, and that it could be quite difficult to translate at times. It often required going back to original legislation and cross-referencing it with statutory language. It did beg the question several times, even among our research team, if we're devoting this many hours to it with our policy expertise, how difficult this must be for sort of your on the ground practitioners who are very, very busy to be able to interpret. So I think it's a very valid point. I just want to share this one anecdote that I think really speaks to the need for clear governor directives and very clear governor language. And this is related to pharmacists in the state of Montana. Now, this executive order is outside of the scope of those that we collected, but in the state of Montana, early on in the pandemic, the federal government authorized pharmacists to provide vaccinations for children down to a certain age, which in many states was beyond the scope of what pharmacists in that state were allowed to do. Pharmacists in that state actually lobbied the governor to provide clarifying language through an executive order, both to clarify what the federal government had said and just because they wanted added assurance that that was in fact okay for them to do. So I bring that up because for me, it speaks to the need for very clearly issued governor directives in times of emergency, especially in the midst of so much chaos associated with the pandemic response. It seems logical that the clearer the language and the more explicit the directives, the more easy for the people who actually need to be tending to the response to interpret.
I'm glad you brought up that example because I was thinking about that same one as well. And I guess just to add to what Meg said, yeah, I think there was not always a lot of consistency or clarity in language. We found, I don't know the number of states, but in many of the states that we looked at, there was an initial executive order. So there was usually an emergency order, and then there was some kind of executive order. And then sometimes there was another one, or sometimes there were 10 that followed after it. And just to sometimes even just clarify the language that had come in the previous ones. And so I'm guessing that they had gotten some questions about kind of the clarity of the language. I mean, the other sort of point that I wanted to make is that in a way, the solution or sort of the advice, I think, to governors would be to coordinate with other governors in other states. But in a way, that's the exact sort of reason for this issue in the first place, is that there wasn't a lot of kind of cross-state or national coordination on these issues. And so each state was kind of left to its own devices to figure out the best language to include, et cetera. So it's a little bit of a sort of circular problem, but I guess if we could wave a magic wand and change one thing about it, that would be one thing we would change, is maybe to have better coordination across states.
Okay, thank you. Well, I think we said we'd wrap up at 2:45. So with that in mind, a final question. If there is one thing we should take away from your presentation, what is it? What are your closing thoughts here is what I'm asking.
I think I may have accidentally just answered your question, basically, which is that I think there was not a lot of cross-state coordination in a way, you know, when we sometimes when people talk about the Medicaid program, they say, like, if you know the Medicaid program in one state, you know the Medicaid program in one state. I think we found a similar thing here, right? Where we felt like if we could understand the language that was in a governor issued executive order in one state, it didn't mean that we necessarily could understand it even in an immediate neighboring state. But we did find some common themes and related to scope of practice and licensing expansions. And I think, I guess the other sort of takeaway is that what remains to be seen is if any of these will be made permanent or even, or sort of turned into legislation or anything.
Yeah, I agree with your point, Julia. And I guess one of the takeaways for me that I would add is just one of those concluding points that we made about the fact that, unfortunately, this is not going to be the last last emergency that many of our current and future healthcare practitioners are going to be experiencing. It is most likely not the last pandemic. And certainly with climate change, there are going to be more and more natural disasters occurring all across the country. And so this is an opportunity for to apply lessons learned and to think proactively about workforce policies that can mitigate harms and be really proactive about the response to these future emergencies. So whether that means coming up with some standardized language across states, as Julia just alluded to, whether it means that states need to be thinking about how to codify these workforce policies in statute so that they're easily available and triggered in times of emergency, might be things that states want to consider doing moving forward, so they can be really proactive about their policy response in future emergencies.
Okay, well, I think that's a good way to end. Thank you, Meg, and thank you, Julia. It was a wonderful presentation. Thank you in the audience for showing up to our event. We, by all means, hope to see you again in the future, and I hope everyone has a good afternoon. Take care. Bye-bye.
Thank you, David.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.